Thank you so much for having me here. It's a tremendous honor. I want to thank the university professors who bestowed upon me this award, Rob for the nomination. I was wondering who he was talking about because I didn't recognize the person, you know, because it's a tremendous honor to say the least. And in fact, I wanted to give a few special thanks, and it's particularly to Rob, right, who I've known for a while. And then I said, you know, I don't have a picture of Rob. And so I said, but the internet has a picture. No, I don't have a picture of Rob and me together. And I said, but I bet the internet does. And so sure enough, I went to the internet and I searched it out. And there we are, right? Right? And, you know, Rob is one of you. I mean, you know him. He's amazing. Great person, phenomenal scientist, and just, you know, there's no one better. And he's been like a friend, a colleague, and mentor. I mentioned the mentor just so you know he's older than me. See, I've lost my hair, but he's older. So I just wanted to say, Rob, you know, thanks for everything. And then I also have to thank someone like really, really special. I mean, there are tons of people who've made it possible for me to be where I am today, but I have to thank like my wife, Virginia. You can see. She and I are a little bit closer than Rob and I are, so you can see that from the picture there. But, you know, you have to understand, I could tell you a lot of stories, but I can sum it up pretty succinctly. You know, my wife is a marathoner. So, you know, life for me is like a guy who goes out for a jog, and you have a marathoner going around with you. So that's what it's like. In fact, you know, she goes out and says, oh, now let's go running, you know. We can talk and run at the same time. And go, no, I can either run or I can talk, but I can't do both at the same time, you know. So I just wanted to say also, thank you for everything, all right? So let me tell you a little bit about anesthesia. And, you know, there's a subtitle here. I entitled it Where Statistics Meets Neuroscience. And that's been a very important part of what we've done. And a lot of it is very simple. It's like just applying statistical principles in a very straightforward way. So I'm going to tell you a little bit, give you a clinical look at what general anesthesia looks like. And then I'm going to talk about loss of unconsciousness under propofol. I'm going to tell you something about the aging brain and anesthesia. Then I want to look into the future. I'm going to talk about building control systems for anesthesia and also this idea of turning the brain back on. And I don't know what sort of concept you have of anesthesia. Actually, how many people here have had anesthesia? Oh, see, it's very topical, see, right? So I don't know what you think about anesthesia at the moment, but the brain is not turned off under anesthesia. It's actually quite dynamic. And I'm going to give you a sense of that. And it's these dynamics that are responsible for how it makes it impossible for you to be conscious when anesthesia is present. And in fact, that's what I said here. This is one of the primary reasons. These oscillations that are going to be generated in the brain circuits are going to make it difficult for the parts of the brain to communicate the way they would normally, and that's going to contribute to a patient being unconscious. And you're going to see that you can see these oscillations very clearly, like in the EEG. They change systematically with anesthetic, with patient age, and they can be used to design control systems. I'm going to give you a sense of that. And then one of the big problems that we face in anesthesia is that patients' brains often don't work after anesthesia, particularly older patients. And so why not turn the brain back on? We turn it off. Why not actively reinitiate it? So I'm going to show you what that's going to look like. So let me start with the definition. So what is general anesthesia? So it's this drug-induced reversible state. It's comprised of being unconscious. You have no memory. You don't feel pain. You're not moving around. And you see, without that word reversible in there, if you take those four things by themselves, they're synonymous with death, okay? So that's not cool on that long list of things that are not cool, all right? So, and where we make our money as anesthesiologists is we maintain stability and control the physiologic systems while this is occurring. And we reverse it and we bring you out, all right? Now, I put this down there, how drugs create the state of general anesthesia is unknown. Nothing could be further from the truth. It just means we haven't paid attention to what's happening in front of us. So, and I'm going to give you a quick insight into that in a second, but let me just tell you something really practical. How do we actually do this? So we actually use combinations of drugs to generate the different states. And if you look there, you see I have unconsciousness. I have drugs like barbiturates and propofol. Then I have the inhalational drugs. So when I say the inhalational drugs, I mean drugs like ether. We still use ether. Sevoflurane, isoflurane, desflurane, they're ethers. You know, going back to like 1846. In fact, in Mass General, we celebrate Ether Day every year, October 16th. Actually, it's coming up pretty soon, October 16th. We all sit around and sniff a little ether, right? No. But you celebrate your anniversary at the hospital there. That's what it is, all right? So the inhaled drugs can do everything. You see, they contribute to each one of the categories, and that's why the discovery of ether was such a major advance in medicine. And then what we try to do is use other drugs along with them so you can have fewer of the side effects and more of the good effects. But for just a standard anesthetic, you have at least 10 drugs without counting, with very, very simple operations. And it gets to be more complex as the complexity of the operation changes. And we use drugs to control heart rate and blood pressure. So I want to give you a sense of what anesthesia is like. So I like to show this video because it gives you, right off the bat, a sense of how dynamic a process it is. So this is an EEG that I recorded about 6 years ago in a woman who was going to have thyroid surgery. She's about 60 years old. She weighs about 80 kilograms. And I'm going to give her a bolus dose of propofol. Propofol is our most used anesthetic, and it works by enhancing GABAergic inhibition. We'll say more about that in a second. But I just want to play this video and just show you what happens. And here. All right. So she has 4 leads of EEG, 2 on the left, 2 on the right, the ground and reference in the middle. And those are eye blinks if you've never seen them on the EEG. Now, in a second here, the EEG is going to get very noisy. It's noisy because I'm injecting propofol into a small vein on the back of her hand, and it burns like crazy. So watch how it gets really noisy. You see that? She's doing this. She's tensing up. And so we said just kind of bear with us for a moment, like bear with us, you know. See, it's getting really, that's actually going to be good for pedagogical purposes. So watch what happens here in just another few seconds. Right here. So you can see when the drug takes effect. Now watch this. Boom. Large, slow oscillations. And watch, more. So she lost consciousness right there. And it's going to get even deeper. She's going to go flat and then burst. And then flat. All right? So what am I showing you? So she went through the following stages fairly quickly. So she was awake up there at A, all right? And the size of these oscillations matters. So that's like 5 microvolts, okay? And then she skipped over the state of where I have paradox excitation there, and she's in a state of sedation. That was the beta oscillations. So to make this concrete, if I wanted to put her in a state so that she could have a colonoscopy, a procedure for which she just needed to be sedated, I would dial the propofol down until I saw that sedation state, and I would just hold her there, basically, just sedation. But she skipped over the next state, which is the one we're going to talk about the most, and she went right to E. You saw the large, slow oscillations. And just as a rule of thumb, whenever you see large, slow oscillations like that, remember, slow wave sleep is the state when the most profound state of sleep. Here, slow waves indicate a very similar phenomenon. It's when the brainstem is most shut down, or the inputs coming from the brainstem going to the cortex and thalamus are most turned off. So right there is when she lost consciousness. And you can actually see it. If you looked at her eyes would have fixed in the midline, and if you checked her reflexes, they were gone. Her brainstem reflexes were gone. Then she went into burst suppression, which we're going to talk a lot about towards the end, and also between the bursts, she's in this isoelectric period. But if you look at the size of those oscillations, see how they get bigger as you go from the awake state to the states down here where she's in the lower panels. So starting from D down to G, those are states of coma. You would see those in a patient who's had a traumatic head injury, or in someone who's in a coma because they were hypoxic. So this is consistent with the idea that anesthesia is inducing a coma, someone who's hypothermic, exactly the same way. But she's at 5 microvolts when she's wide awake, and down here, these are like 20 to 50 microvolts as she's anesthetized, and this can go up to 1,000 microvolts in kids, as we'll see in just a bit. All right, so this is not a subtle change. And in fact, this is the strongest EEG signal there is for all the things that the EEG is used. So I'm going to show these not as time series. I'm going to show them as spectrograms. So this is showing an EEG of a woman I took care of a few years ago. She's about 20 years old, 19 years old, and I'm going to give her 200 milligrams of propofol, and then I maintain her on an infusion, okay? So over time, you see a signature of propofol, and it's this oscillation, which you can see above there. It says slow and alpha oscillations, and it's doing this. You have a low-frequency oscillation like this, and then a high-frequency oscillation riding on top. So when you look at that in the spectrogram, when you break it down over time, time is on the x-axis, the size of the amplitude, the frequencies are on the y-axis, and the amplitude is coming out at you out of the board. And you can see where you have the two red lines there together. So there's a red line. The top one is the high frequency, 10 hertz, and the lower one is the lower frequency, about 1 to 4 hertz. So this is a signature of propofol. Just like your voice has a signature, the drugs have a signature. And the signature depends upon the mechanism of how they're acting in the brain. And you can see it very clearly. So I just want to show you another little bit of phenomenology here, then we'll talk mechanism. So there's a dynamic to the oscillations over time, and there's also a spatial dynamic. And so we've done studies in volunteers where people volunteer and let us anesthetize them. So like if next Saturday you're not doing anything, come by and we can, let you see it from the other side, as it were, right? But so in these studies, what we do is we put EEG on patients, whole head EEG, and we give them increasing doses of propofol, increasing it for an hour, then decreasing it. And so what you can do is measure how the EEG changes across the entire head when this occurs. And that's what I'm showing here. Now, I just have to remind you of one little bit of physiology. If you stand here like this and you close your eyes, and I put electrodes in the back of your head, you'll get what's called an eyes closed alpha oscillation, a 10 hertz oscillation, 10 cycles per second. Pretty much everybody has it. We lose it a bit as we get older. Maybe about 5 to 10% of people don't have it, right? But this oscillation is very robust. And that's what I'm showing here. So these are 44 of the 64 leads that we typically put on a patient's head. The nose is up top, the left ear is over here, the right ear is over there. And you see these two spectra in the back are the two that are recorded right here. So this male patient is lying there like this, and he has his eyes closed, and he's generating a 10 hertz alpha oscillation. So he goes 0, 10, 20, 30, 0, 10, 20, 30. He's got a 10 hertz alpha oscillation. Now, when I give him propofol, as I increase the dose, this alpha oscillation is going to move from the back of his head to the front. It's going to concentrate in the front, and then when I turn it off, it's going to move backwards. Right? So that's the alpha oscillations. That's what's called anteriorization. This was discovered by John Mitchenfelder and John Tinker in Minnesota at the Mayo Clinic back in 1977. They reported it. Well, let me just show it to you. So we're going to be increasing, and so you see where it says baseline up there. That's where you can see what the drug level is. So right now the infusion is going to start. So it just started. Now watch what happens. Watch how this breaks up. It breaks up, and now it's going to move to the front. And we're not even at the deepest level yet. It's just at 3, all right? So there's 4. See, it's concentrated in the front. It's disappeared from here in the back. And now we're going to, 5 is the top, the deepest level. Now we turn it off, and it moves back from the front to the back, all right? So that's anteriorization. So not only is there a temporal dynamic, but there's a very highly structured spatial dynamic across the head, which happens with anesthesia. All right, so how do we put this together? So you can draw diagrams like this here. And so propofol works by finding inhibitory interneurons, and it enhances their ability to inhibit. And so where are those interneurons sitting? Well, they're sitting everywhere in the brain and through the central nervous system. But I put up 3 sites here, in the cortex, in the thalamus, and also in the brainstem. So you can draw a diagram like this. So it has to be hitting these sites. And it's very lipophilic, so it goes everywhere. You go to the operating room, and like I showed you, you see something like this. All right? And then you go to the laboratory like we just did, and you see this frontal alpha oscillation. The question is, how does it come about? Well, here's what happens. The Alpha oscillation, I have to tell you one other thing about it. It's in the front, as I showed you, but it's also quite coherent. So if you measure a frontal electrode here, and you measure a frontal electrode here, and you measure the correlation between them at 10 hertz, it's very high. It's 0.8 or 0.9. It's concentrated in the front of the head, all right? So this led us to think about this probably being an oscillation going back and forth between the thalamus and cortex. And so working with my colleague, Nancy Coppell, who's a mathematician at Boston University, she developed a model describing how, along with Shinung Ching, who was the postdoc at the time, that this oscillation was most likely a phenomenon going back between the thalamus and the cortex. And now what we've done is stuck electrodes in the thalamus of rodents and also the thalamus and cortex of non-human primates and show that this oscillation is indeed there. But why would this make you unconscious? Remember, the thalamus is an important way station. All sorts of information comes through there: visual information, auditory information, sensory information, pain information. So if you tie up the thalamus, particularly with the frontal cortex, which is where we reason, it's going to have a very potent effect and make it very difficult for someone to be conscious, all right? So that's okay, but these, I think, are the most compelling data that I have about what happens in humans. So we have patients who come for epilepsy surgery, right? So that means they get electrodes implanted in their brains, and they stay in the hospital for a period of, so they failed all drug therapy. So they get electrodes implanted in their brain. They stay in the hospital for 5 to 7 days. Once they've seized enough off of medications, then they come back to the operating room, they have the electrodes removed, and they eventually have a resection of the area where they think where the epileptic focus is. So when the person comes back to the operating room the second time, we have a natural experiment. And the natural experiment is we can just record from the electrodes in the human brain, and see what neurons in the human brain are doing when you get anesthesia. So that's what I'm showing you here. So look on the left here. So the traces, the colors, correspond to locations here on the cortex. And the line below there shows you the neural spiking activity. And the neurons are just, and this neuron is just spiking. This is a neuron that's sitting next to the red electrode. So it's spiking wherever it wants. The person is conscious. Now look how the spiking changes when the person becomes unconscious. That neuron, which is next to the red electrode, can only spike now. 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 It's basically every 2 seconds or so, okay? So, and the same thing is happening on the neurons next to the blue electrode. So you have this picture of all these neurons being out of phase. So in other words, if we have to be in phase in order to communicate, in other words, be able to send spikes within the same time window, I submit to you this is going to be a very, very difficult state to communicate, and it's probably going to contribute to this person being unconscious. Let me show you a better picture of it. So this is from some recent work done with Earl Miller at MIT and Jake Donahue, this is from his PhD thesis. And this is showing you this in the non-human primate. See, the different brain regions are indicated. There are 2 frontal regions, a parietal region, an auditory region. So this is looking across essentially from the front to the back of the brain and seeing the different spiking activities in the different regions. And you can see how they're broken up. You have these large pieces where they're coming in phase, they're coming out of phase, they're coming in phase and coming out of phase. This is what you see with the slow oscillations. So this we also think is a major reason that people are unconscious under anesthesia. Okay, but let's get practical about this. So like, who cares, right? You know? So here's the thing. We were talking about this at lunch today. You know, when you go to a cocktail party, right, you don't sit around and go, hey, you know, those anesthesiologists, they're some really cool people. They do all sorts of neat stuff. They anesthetize you and bring you back and what have you. You don't hear that. You hear about us when we screw up, right? And so you read an article in like The Atlantic or something that says, you know, once again, another case of a person being wide awake under anesthesia, and the anesthesiologist was clueless about it, right? That makes it, right? All right, so let me just tell you the facts. Awareness under anesthesia is not a public health crisis, okay? It happens 1 in 2 to 10 to 20,000 cases, right? But the fact that it happens at all is disturbing because it shouldn't. And one of the reasons it still occurs is that anesthesiologists don't use the EEG. What I just told you here is not standard of care. This information is very easy to read, but it's not done. So that's why these incidents still occur. So that's why it's very important to appreciate this. And then I've told you about propofol. We could look at all the other drugs. They look like this. If you look at them in the frequency domain, they look this way. So you can see the drugs have different signatures, which are pretty easy to identify, and they do reflect differences in drug classes. And then it goes further than that. We can do an analysis of each of the drugs the same way I just talked about propofol and give you mechanistic insight. Here's a key point I want to make. General anesthesia is not sleep, all right? So, but it's even a little bit deeper than that, right? Let me say it this way. So first of all, if you look up there, see, that's the person wide awake on the left. That's just sort of standing there. You see on the right over there, those are the eyes closed alpha oscillations. Those are the ones that are generated in the back of the head, all right, when you close your eyes. All right, now if you look over here, these are the states of anesthesia that I showed you in the other slide, where what we do is when we anesthetize you, we bring you into one of these states and your brain just sits there and oscillates like this. It's just doing that. What is sleep, though? Sleep is REM, is non-REM, REM, non-REM, REM. You cycle every 90 minutes, and that's what I'm showing you over here. You go to non-REM 1, 2, 3, then you cycle back up to REM. You do that about every 90 minutes. You do that about 4 to 6 times a night, all right? So that's quite different from being held in one of these states, but it has very practical implications aside from just sort of understanding it scientifically. If you thought about the sleep medications that are typically taken, particularly GABAergic ones, things like the midazolam or the benzodiazepines, or a drug like zolpidem, which is Ambien. If you thought of them as weak anesthetics, that's actually a much more accurate description of them. Because what they do is they sedate you, right? And then what you hope is that your natural sleep mechanisms take over. But if you think about it, no drug can make you do this, all right? So it's just important to understand that the sleep medications are basically just weak anesthetics. They just sedate you. So here's what happens with age, all right? So over there on the far left is someone who's 30 years of age under propofol, all right? And then if you look down here, here's someone who's 57, and you can see there's the pattern, the 10 hertz oscillation, the slow delta oscillation, and you see the same thing here. Now look on the far end over there. There's someone who's 81. So you can see if you look carefully, she has 10 hertz oscillations and she has the slow delta oscillations, but the amplitude is less. So the 30-year-old looks like this, the 57-year-old looks like this, and she looks like that. So these are just normal changes that you see with aging, right? And one of the things, because I was taking care of her, this was a patient, as I said, who was 81. She had a tumor on her chest the size of an American football, and it took the thoracic surgeons the better part of 6 hours to remove it. And we were able to give her essentially one-third to one-fourth of the age-adjusted doses of the anesthetics because we're following her EEG, right? And we were able to wake her up on a dime. The part that's a little sobering, if you would, is like here, where, see the 56-year-old and the 57-year-old? The 57-year-old looks like the 30-year-old, the 56-year-old looks like the 81-year-old. And you go, you know, what's up? So we age different physically. It makes sense that our brains probably age differently if we haven't been that good to ourselves, you know, over time. You know, it might show up. It's kind of like going to the hairdresser. Only your hairdresser knows what your hair color really is. You know, only your anesthesiologist knows what state your brain is truly in, right? That's probably what's happening here. But this is something which we're actually going to start looking into because it might be a way of having a stress test for the brain the same way you have a cardiovascular stress test for the heart. You know, just giving a little anesthesia and seeing what the oscillatory dynamics are like. But look at the kids, right? The 3-year-old, the 14-year-old. The power there in the spectrogram is enormous. If you look at it this way, you can see the same thing is happening across the age spectrum. It's just that the spectral bands have gotten broader. And actually, the most power in the spectrum is actually when kids are between when people are 6 to 8 years of age. And after that, it's all downhill, you know. So the 22-year-olds out there, you're on the downhill slope too. So, don't get smug about this, right? You know, it's the 6 to 8-year-olds that have the most power. But you can see why some of these indices that are used that are built on people who are in the 30 to 57-year-old group, when they're used in the operating room to track the brain states of kids, they don't work as well. Right? So age is a very important factor. So now if we look to the future, what kind of things could we plan to do? I want to tell you a little bit about medical coma. You've probably heard about this, and these are 3 very well-known people who were placed in medical comas because they had head injuries, right? And so what is a medical coma? You actually have seen it now. All you do is you give like a very large dose of propofol or one of the other anesthetics, and you hold the person in a state till you have burst suppression, and you keep the burst suppression there for an extended period. Now, the extended period could be several days, because what you're trying to do is let the brain swelling come down, letting the brain rest, or you're trying to stop seizures that don't respond to sort of standard therapies. So what's interesting about this, the way it's done, is you just set the pump and you kind of guesstimate how much burst suppression you want to see, and you just start the infusion running, and after you make sure that there are no significant change in blood pressure, the nurse just walks away and may come back a few minutes later or an hour or so later. In other words, no one's watching it. So if there were ever a perfect time to have a control system, this is it, right? Because it's like flying from here to Tokyo, right? And going, okay, I think Tokyo's about that way. I'm going to go that way. And then you go off and talk to the passengers, right? And then you come back and go, oh, gee, we're heading to the North Pole. Then you put the plane back on course, right? All you need is an autopilot. So that's what we worked on building. All right, so here's the illustration. So we have these rat volunteers who come over to the laboratory, and here's one of them, all right? So we have this system, which is just a closed-loop system. We just read the EEG in real time. We convert the signal. You set a target level of burst suppression that you want. And let me just show you this. So you see you have burst and suppression. So if you say you want the target, if you want the person to be 60% suppressed, so that means they've got 40% of their time they're going to burst. So you can set that target, and then you can estimate that in real time using a recursive algorithm, Bayesian algorithm, and then you compare where you want the person to be with where they are, and that tells the controller how to change the infusion pump. So very simple. I mean, I think this is very funny, like a statistician telling engineers about a control system. I think that's like hilarious, But anyway, so if I can build it, it has to be simple, right? All right. So, but that's what we did. So let me just illustrate it to you here. So here's a case of it. So this is an illustration done by Miriam Sinetti, who's one of my graduate students. And then she stayed on for a postdoc, and now she's a faculty member out at USC in engineering. So I'm going to set the target. See, the target is 40%. I want it to be 40% suppressed. That's the EEG up top. This here is the infusion rate of the pump down here. So the pump is changing its infusion rate on a second-to-second basis. And so you can see what the target is actually doing. So now we increase it. So we want the animal to be 70% suppressed. You can see the EEGs up there. And now the pump dynamics are actually quite different, right? And you can see it's holding the target relatively well, all right? And so now we're going to increase it again. We're going to go up to 0.9. Want the person to be 90% suppressed. So it jumps up. The pump dynamics are also different here. But you can see the idea of maybe having a controller do this is not, it's probably not that, it's probably very feasible, actually. So I showed you like this example here. I showed you animal 2, right? So everything is going up, going up, going up. Now look at animal 4 there. You see, now you have to come down. Well, to come down, I don't have a drug that can take away burst suppression. So what the controller does is it turns off the pump. The trajectory glides down, and then once it reaches the level where it should be, the pump turns on again, all right? So it's like it's a jet when it's going up, and it's a glider basically when it's coming down, right? But it should be totally feasible, right? So we wanted to take it a step further, and we wanted to try it out in a model that would reflect something which you could do in the operating room. So we tried out the non-human primate model. And I must, we had with Marshall Herbert this afternoon, we were talking about self-driving cars. So you have self-driving cars running around your streets here, right? Do you know the FDA has approved no closed-loop system for anesthesia? So we're trying to get FDA approval to test this out in humans. And I'm just thinking, like, if the FDA had been in charge of self-driving cars, just pointing that out, all right? All right. So we wanted to do this in non-human primates. And so this is work done by my postdoc, Suresh Chakrabarty. And so we found this level of unconsciousness which we could build into an index. And let's say when the animal is unconscious, it's at a 1. And I won't go into the details of how the index is constructed, but let's just say 1 is the target. So 1 is adequate anesthesia so that we could actually operate on him or something like that. And so what we're going to do is Suresh is going to do it manually first. He's going to try to hold the 1 just by him turning the pump himself. And then what he's going to do, he's going to turn it over to the computer. And we're going to see, so like, who can do better. All right, so that's Suresh trying to hold 1, all right? And, not bad. I mean, right? Now we're going to turn it over to the computer and let the computer take over. Right here. And so now we'll just drop it down a little bit to make it go to a slightly lower level. Right here. And then we'll raise it up again, above where we were before. So again, something which is like totally feasible. So this would be a big help, like in long operations, like 11, 12-hour operations where you have spine surgery or something like that, and you want to keep a very, very stable state of anesthesia, certainly in the ICUs like we talked about. All right, so one final idea. All right, so we give you anesthesia to put you in a state of general anesthesia. We should wake you up. So as I said, here's another one of our rodent volunteers. And he's in this cage where he's nicely anesthetized. So he's been there for about 20 minutes or so. And so this is work done by my colleague, Ken Soul. And so he's out cold. And what Ken is going to do is he's going to give him Ritalin, the same Ritalin that we use to treat ADHD. All right, so he's totally out. So Ken has to flush it into the Now, we didn't turn the anesthesia off. It's still going. Right? It's still going. Right? So let's just say there's a state change of some kind, right? All right. So now he's got to turn over for this to count. It doesn't count if he doesn't turn over. And he's managed to get his feet caught in the wires. He does make it. I've seen the end of the video. Come. Okay, he got it. All right, that was great. All right. So what's happening here? All right. So here's what's going on. So Ritalin works by blocking the reuptake of dopamine. So it keeps the dopamine levels in the brain high. And it does it in a very important pathway. This pathway, which starts in the VTA, going up to cortex through the limbic system, it's called the mesocortical pathway, or the mesocortical pathway. It goes to the limbic system, and dopamine is here. We usually think about this as being a reward system, but it's also extremely important for cognition, right? It's distinct from the nigral striatal pathway. And we've done this, just by giving intravenous Ritalin like this. And Ken has also done it by stimulating optogenetically, specifically the dopamine neurons, and showing you can get this very, very precisely, and also with electrical stimulation. And maybe the scientific explanation is interesting, but I think the more compelling information is what I call science from the word on the street. So there's this really cool article in the April 15th, 2015 issue of New York Times, in which this woman has a startup company, and she gets this letter from her investors, or she gets a phone call or text, and they say, we want a new financial plan on our desk first thing in the morning. It's almost 11 o'clock. She goes, ugh. So she calls up her dealer. This guy comes up to her third floor apartment in New York, and he brings her a bag of pills. She gives him a wad of money, and she gulps one down, and then she decides to maybe take another one. And she says, after about 10 minutes, she said, I felt my brain snap to attention. And so this is this phenomenon of people using these drugs like Ritalin and Adderall, they self-administer to keep their minds sharp. And a lot of people in high-stress jobs do this. Let me be clear, this is not smart. Do not do this, right? All right? But it's science from the word on the street. The word on the street is these drugs make your brain sharp, right? So if people's brains are not working after anesthesia, why not take advantage of what the word on the street is telling you and use this as a new therapeutic option? When I first found out about this, my son said, Dad, what do you think? You've discovered manna or something like this? Everybody knows that the kids get, Ritalin from their friends before their SAT exam. So this thing is sort of, very, very common. So something that we're looking at, we have a clinical trial looking at this now, and it seems very, very feasible, right? So this is what I've told you. The brain is not turned off under anesthesia. It's actually quite dynamic. And we think that a principal mechanism through which the drugs are working are generating these oscillations which impair how the parts of the brain communicate. I've shown you what these oscillations look like on the EEG, how they change with drug, they change with patient age. I've shown you how they might be used to generate a control system. And I've shown you something about turning the brain back on. And I just want to leave you with this idea here. So this is the anesthesiologist's view of neuroscience. Like we're in the middle, like right there, and the rest of neuroscience sort of rotates around us, No, but it's actually true to some extent. If we took seriously the neuroscience and what we did, right, we could make a lot of robust connections with a lot of problems. So pain, for example, we use ketamine to treat pain. Ketamine is a model for schizophrenia. Ketamine is also a way to treat depression now, right? Or if you take epilepsy, you can use a drug like methylhexatol to induce seizures. At low dose, at higher doses, it'll actually treat seizures. Or you can generate a locked-in syndrome in someone by just giving them a combination of droperidol and fentanyl. So there are all these phenomena that we know about that we could improve upon and use in a therapeutic sense for other problems in clinical neuroscience. And we could learn from clinical neuroscience to improve anesthesia if we started taking anesthesiology seriously as a subdiscipline of clinical neuroscience. So that's what I just want to leave you with. So thank you very much. And I'll just leave my research support here. Thank you.
I think it's my job to ask a question, so I see one right now. Go ahead. Can you say it loudly, though? Are you getting the mic?
Thank you. Thank you. I had anesthesia back when I was in the 70s, like I was losing teeth out. And then more recently, I had an operation, I had anesthesia again. And something has changed about the phenomenon. So in the early days, there was no sense of time passing. The moment I got it, then it seemed like 1 second and a half and I was waking up. More recent, more delicate ones, it doesn't feel like that at all. So can you say something about this time, this perception of passage of time while you're anesthetic?
No, so that's a good question. So typically when you have general anesthesia, you do lose the perception of the passage of time. And and I'll be frank with you, I don't know why that happens, but it's a very, very robust finding. People typically wake up and said, have you started yet? Or they're surprised to find out that you're actually done. So that's more typical. And what I would suspect happened to you in the second operation is they didn't put you completely under. They just probably sedated you. Particularly if it's something like just for your wisdom teeth, they probably just used like midazolam and fentanyl just to sedate you to actually do the operation. Whereas before, people were probably a bit more heavy-handed and put you under complete general anesthesia for it. So I think it's so you were in that sedative, remember I showed that sedative state? So you're probably more like in that sedative state in the second case. That's why you can still perceive time passing because you probably woke up intermittently and were talking to them and didn't even realize it.
Two questions. I'll start with the simple one.
Okay.
Number one, have you tried reawakening with Taplin? And number two, there have been some studies suggesting there's maybe a correlation between exposure to anesthesia in children and long-term cognitive outcomes.
Right.
Could you speculate on the cause?
Yeah, no, so two great questions. So first of all, So we've used Adderall. We used Adderall, and so you see a similar phenomenon like with the Adderall. So my suspicion is if it were specifically modafinil, you would see something similar. And the whole idea here, the way this is working is, like when you have an opioid overdose, the way you turn off the opioid overdose is you have something which specifically goes and competes for the opioid receptor and sort of moves the opioid off the receptor. This is different. What you have here is you have a neuron here, or let me say it this way. At all times, there's a balance between inhibition and excitation in our brains. Under anesthesia, we push it more towards inhibition. And all we're doing here is we're finding an important excitatory pathway and driving. It's the one with, via dopamine. So I say this to say that drugs which do the same thing would be predicted to work, like modafinil, for example. And then this is a big issue about kids in anesthesia. So the good news is what's been shown recently in at least 2 or 3 studies is that children who have just limited exposure, like 1 or 2 exposures to anesthesia, there's no issue with cognitive impairment. What's being looked at now are kids who have longer exposures, multiple surgeries, and that sort of thing. The difficulty is there's an important confound. The kids are sick. They have a condition that requires them to have multiple anesthetics. And so is it their pathology or is it, the anesthetic? And I think that's going to be harder for us to tease out. And the first thing I would say is you certainly wouldn't advise those kids not to have their surgeries or what have you because of concerns about the anesthesia, because usually the procedures they're having are life-saving.
How about back there?
I was hoping you could speculate on the connection between some of the work that you've described and creativity and intelligence. That was the first thing I was wondering about. I know some people report interesting phenomenology in that respect. The second thing I was hoping you could reflect on was how some of this research might be relevant to treating or preventing neurodegeneration.
So let me take the second question first, the neurodegeneration. So one of the things that's these states of anesthesia that I show you here, right? So it's basically, I'm just going to go back to this slide here. It's great that we have these, let's say here, right? But these are not natural states. Your brain doesn't naturally go into states that look like this. So what we should be thinking about is how can we produce anesthesia in a more physiologically sound way? And maybe when we're younger we can tolerate this, but as we get older we just can't. So, and then one of the things that seems to be, inflammation is tightly linked to a lot of, to neurodegeneration, particularly like Alzheimer's. And one of the things that has been shown by Zhang Zi, who's at Mass General there, is that these anesthetics actually facilitate the formation of A-beta plaques in older rats, all right? So again, you would not have your surgery because you're worried about that happening, but it just says that we need to find some other ways of doing this. Now, mind-expanding experiences and creativity, are you referring specifically like ketamine or something like that?
I believe that's
Okay, so I don't know anything about that.
Yeah, go ahead.
I've had the enjoyment of being under general anesthetic because it's fun for the first person, but I also had when I was little, I went into a coma from malaria. I think it was like 18 hours. I don't remember the coma part, that's fine. But when I came out of it, for like several days, I was basically in a state of like half sleep, and also my body. So was that basically an extended version of like coming out of anesthetics? In other words, had they given me Ritalin, maybe I would have been good to go. I was 5 or 7, around between 5 and 7 at the time. Is that what's happening?
It could well be, but see, the other thing to realize is that being in a state like that where you had a malaria infection, you said, right? So, right. So, I mean, that is a huge load of inflammatory mediators in the body. And one of the things the inflammatory mediators do is they shut down the arousal systems. They bind to the arousal system and shut them down. It's a physiologic response. So for example, when you get sick, right, you don't feel like running a marathon. You want to sleep, you want to lie down. So now imagine you've had a rip-roaring infection like you did for an extended period, and to think that all of a sudden, just because you're awake, the system is going to be back to normal. That's probably what happened. So the anesthesia might have contributed to it, but it could have very well been just the inflammatory load that you had from the malaria. Because your arousal systems are still somewhat suppressed.
Over here. And then,
my daughter has narcolepsy, and for years she's taken a drug to stay awake during the day and another drug to sleep at night.
Right.
And I guess two things. As far as I know, there's never been any analysis to see if she's getting proper sleep. Is she just being anesthetized? And you just mentioned the long-term harmful effects of it. Is she looking towards early Alzheimer's because of this? She's done it for years. She's been on
right.
this.
So let me just be clear. So I think that we don't know yet per se that being in these. In other words, we're concerned about repeated exposures, of anesthesia maybe causing problems. All right. Now, what's really clear is if people aren't able to sleep, sleep deprivation is actually quite harmful. So the fact that she's able to get rest is actually better than not having her rest. And actually what happens is the narcolepsy comes about, and you probably know better than I do, because she has a deficiency in orexin or hypocretin, which is another one of the neurotransmitters there coming out of the lateral hypothalamus. Right? And so since it's not there and providing its excitatory input, then she would tend to fall asleep like during the day. And so you need something to help keep her awake. And because she maybe lacks the hypocretin, her normal sleep mechanisms don't come on, sort of the correct way. So at the moment, we're starting to get some insights from our work in anesthesia on how maybe design better sleeping medications. And it's an open question as to whether or not they would, which would be slightly more physiologic, let me say it that way, as opposed to just giving you GABAergic drugs. It's an open question as to whether or not they would work better in people without disorders, and also whether they would be of help to someone like her who has narcolepsy. But it's something that I basically think about every day, and we're working very actively on.
over here.
In your studies, you were using inhalational gases most of the time. Did you see a difference between when you were using a total IV anesthetic as opposed to an inhalational gas? Do you see difference in the brain responses?
So it's very interesting that you asked me that. So starting about 3 years ago, I changed over. In my personal practice, I use almost no inhalational drugs. I do total intravenous anesthesia. So the idea is that I do everything. I don't use any of the ethers in my practice. And part of it is that there's this sort of technique that we've been working on, which is called multimodal anesthesia. And the whole idea behind multimodal anesthesia is to get better control of the pain system by using drugs that act at multiple locations. And what happens is, because they also decrease arousal, you can use less propofol to then make someone unconscious. And I can do that in a much subtler way if I do it total intravenously, as opposed to using the inhaled drugs. And at least in my hands, I couldn't get the same subtlety of response. I can wake patients up on a dime, by doing as I just described, whereas I don't have that same subtlety with the inhaled drugs. And it reflects I think it reflects the fact that you have to breathe them in and breathe them out, so you don't have the quick on-off like you do, let's say, with propofol, that sort of thing.
Hi, you were speaking earlier on how medically induced comas can help with providing more time for injury. Can you speak a little bit more on how that comports with inflammation?
I'm sorry,
can you speak a little bit more on how that comports with inflammation?
Right, so part of the injury that, let's say someone has a traumatic head injury, part of the injury is not only just the physical derangement of the brain tissue, but it's also the brain's response to it, the inflammation. And, it's natural for it to happen because it's part of the repair process, but, it's part of the solution, but it's also can be part of the problem as as it continues to persist. So, you know, and it's really obvious in surgery, you know, someone has a procedure, you know, where they have an incision that comes from maybe their sternum, you know, down to their, you know, their belly button or that sort of thing, and they're splayed open. I mean, you've really torn tissue, you've cut tissue, and that's a huge inflammatory response. So this is my thinking evolving. You know, we try to be very judicious in how we give patients pain medications to treat that situation. I actually think that we should put more emphasis on using anti-inflammatory drugs in that setting. And I do that. So for example, at the end of the case, right, I will run in intravenous Tylenol on a patient just for this reason. In addition, because controlling inflammation helps decrease the response of the pain system. And in fact, we have a protocol now that we're doing at the Beth Israel Hospital in Boston where we actually do that. So the patients get 24 hours of intravenous Tylenol. And we think of it for pain, but it's also helping to treat pain by shutting down or decreasing the inflammatory response. And I think this is going to become more and more part of our thinking because inflammation and the immune system is really everywhere. I mean, it helps us, but it also works against us at times.
One more.
Thank you. I've heard a lot of specific questions, and I want to ask a more general and philosophical one.
Okay.
Actually, like, so unconsciousness has been kind of a myth for psychologists for so long, and I mean, as such a profound neuroscientist who knows so many underlying mechanism of how brain works, and who study unconsciousness for so long, how would you view the difference between idealism and physicalism?
What?
Okay, so physicalism is more like you think everything going on in your mind is probably like physical activities, but idealism believe there's something called a notion of mind that you can't really explain what is happening.
I mean, so it's a fantastic question. So I'll just respond with a little allegory. So in the most recent issue of Anesthesiology, there's a commentary in there by an anesthesiologist where he ended up in the emergency room. And he ended up in the emergency room because he had unfortunately, these bad hemorrhoids that had to be attended to like right away. And as you know, hemorrhoids are very, very painful. And so they decided to give him ketamine for this procedure. So his wife was there with him, and so this is him telling his story. It's in this month's issue of Anesthesiology. So they give him ketamine for this procedure, and it's very graphic, the explanation that he gives. He said he feels himself come out of his body. He can see he can see what the people are doing to him as they're treating him, and then he feels himself sort of then go back into his body. All right. And he says, so going to your question, he concludes that, you know, the mind is not part of the body. That's what he basically says, right? I'm not saying I'm saying, I'm just saying that this is what he said, right? Right. So it's a very, very interesting question, and it goes to the heart of, you know, how we think about consciousness. You know, what does it really mean to be conscious here and, you know, present now? And one of the very fascinating questions about consciousness is exactly that. You know, how do you know that you're in the moment? You know, what is it? How is that represented so that basically occurs? And you see, here's now where I can totally cop out. I've studied unconsciousness, not consciousness. And let me draw the analogy here. You see this cell phone, right? It works, right? Complex advice. I don't know how it works, right? I know if I take the battery out, it'll stop working. I put the battery back in, it'll work again. So that shows you where my research sort of sits relative to understanding consciousness, right?
All right.
Right. Thank you.